As for our first presenter, I have Dr. Krychek here with the pulmonary team in Council Bluffs. He is going to be speaking on asthma, COPD overlap, and management challenges. So welcome, Dr. Krychek.
All right, thank you. I'm a pulmonologist over in Council Bluffs. I'm a general pulmonologist, but honestly, my area of interest lies in both asthma and COPD. I see everybody, but when I get the chart that says asthma or COPD, that's when my eyes light up, and that's when I get excited, because those are the patients that I really feel like I can help. And so I selfishly chose this topic so I can talk to you about both disease entities. There is, in fact, asthma COPD overlap. You maybe have heard of this, maybe you have not. This is actually fairly common, in fact, as I'll show you. And there are some unique opportunities. Now, I put challenges in my title, but I'm going to emphasize opportunities in managing these patients that are actually the highest risk patients that we will see. All right, so I have to start with some disclosures. Again, these are my areas of interest and I guess expertise. I do a little bit of speaking for a few of the drugs that these patients are often prescribed. So I disclose that there, but I'll tell you I took every step I could to mitigate any bias with the actual evidence and data that I'm going to show you over the next 45 minutes or so. So, as mentioned, over the next 45 minutes, I want to talk to you about asthma, COPD overlap, and we nerdy pulmonologists actually kind of hotly debate this topic. I'm going to the CHEST meeting, our biggest meeting of the year, tomorrow in Boston, and I guarantee you there will be a couple of sessions here where we're arguing about whether or not this disease entity exists and how do we diagnose this and what's the definition, and we'll go through that just a little bit. That is and is not important, because at the end of the day, what it comes down to are the treatable traits of these two distinct separate entities, asthma and COPD. We're going to talk a little bit about inflammation, and that's what matters. Whether they smoke, whether they have asthma, it's the underlying inflammation that we're targeting with our medications to improve their symptoms and to improve their outcomes. And we'll talk more about that. But clearly, we need a little bit more research in this area, because studies with asthma exclude COPD patients. Studies with COPD excludes asthma patients, and yet these are two heterogeneous conditions. There's significant overlap, as we're going to talk about, and we really need some studies looking at both patient populations together, both disease entities together, to really have a meaningful idea on how we can improve outcomes. So let me start by telling you about one of my patients that I saw not too long ago, and she's kind of my poster child for this disease entity. So I saw her recently, and then I reviewed her chart so I could tell you her story. So she's a 65-year-old lady. She had an extensive smoking history, and she has asthma COPD overlap, and I recently saw her in my clinic. So it was a 6-month routine follow-up, and fortunately, she's doing great. Her validation questionnaire, the asthma control test, her score was 24 out of 25, which is outstanding. She reported no exacerbations. She's now on a medium dose inhaled corticosteroid, LABA/LAMA, so a triple therapy, and just at the medium dose, no longer needing the high dose. And she's on an asthma biologic, and we'll talk more about that. And she came to see me very happy because she's lost another 30 pounds in the last 6 months. She's lost 90 pounds under my care. And at age 65, she went back to work. Most 65-year-olds are pretty happy to retire. She was thrilled to be going back to work, went back to work at Panera, Employee of the Month in her first month. She actually showed up in her Panera hat and t-shirt just to show me that she was back to work. So she was really, really happy. But let me tell you a little bit about all the steps that kind of led up to her coming to see me. So she actually came to the Creighton Pulmonary Fellows Clinic 5 years ago, January of 2019. She was still smoking. She had a significant smoking history of 60-pack years. She was morbidly obese. She did tell them, I have a history of asthma. but of course they focused on the smoking and the COPD. And she said, I hadn't been breathing too bad until about the last year or so, when she'd been having several exacerbations requiring a lot of prednisone. And her primary care physician said, I'm going to send you to a specialist, and they sent her to Creighton. And she wound up in the Fellows Clinic. And so they did PFTs, and she had severe obstruction. Her FEV1 was just a little over 1 liter, only 40% of predicted. So that is gold stage 3 severe COPD. But she had a lot of reversibility. She had a lot of air trapping, and her diffusion capacity was only moderately reduced. They got a CT scan. She did, of course, have some emphysema. She was in extremis in that day, so they gave her a prednisone burst. They put her on a high dose triple inhaler. So at that point, she was on the high dose inhaled corticosteroid. They did check some blood work as I looked back, and she had a very high eosinophil count. And we'll come back to that in a bit. So she went home, took her new inhaler, took her prednisone, came back, and she still wasn't doing very well. So they put her on chronic prednisone. We do everything we can to avoid that. The patients need to breathe, and it was felt that this is what she needed, was 10 milligrams of prednisone every day. She successfully stopped smoking, but unfortunately, she continued to exacerbate over the next year. And so she finally came to see me. And I sat down and I looked at everything very carefully, and I saw the biomarkers, her eosinophil count and her mildly elevated IgE. And so I elected to put her on an asthma biologic, and we're going to talk more about what that means here throughout the talk. And with that, she started noticing improvement. We got her off of the prednisone. We got her out of the wheelchair that she came to see me in, and she started walking, and she went to pulmonary rehab, and she was incredibly motivated to improve herself. And through exercise and adherence to her medications, and with this asthma biologic, which played a significant role in improving her symptoms, she got better. Her lung function got better. Her lung function went from 1 liter to 1.6 liters. That's a 500 milliliter improvement. We don't see that in pulmonary medicine with COPD. So that's quite remarkable. And so she clearly had a very significant asthma component to her COPD and responded very well to aggressive management of that disease condition. So, little background here about asthma and COPD. As you are well aware, these are very common disease entities. I have good job security. There are a lot of these patients, and as mentioned, I enjoy seeing them. These are classically described as separate disorders, but we know that there's a significant portion of patients that have features of both. And recently, there's a lot of emphasis in looking for these patients because we're finding them, and as we're looking at phenotypes, as we're looking at their blood work and their eosinophil count and their IgE level and these sorts of things, we're doing a better job of recognizing that not every patient with COPD only has COPD. They maybe had pre-existing asthma, or they have developed asthma while they are smoking. And it's important because we can tailor therapy more appropriately than just saying, oh, another patient with COPD, and here's an inhaler, good luck. Prevailing evidence used to be that there was 10 to 20% of patients with COPD that hasn't had an asthma overlap. More recent evidence in this era where we're looking at biologics, we're checking the eosinophils and the IgE, and we're determining the type of inflammation. Current evidence would suggest it's more like 30 to 40% of our patients with COPD. So when you're seeing a patient with COPD, please consider this as a disease entity, and you're not going to find it without looking for it by asking questions and looking at their labs and their PFTs, as we're going to talk about. The problem is there's a lot of controversy, as mentioned, with how we fully define what asthma COPD overlap really looks like and what it is and how do we define it, because there's no globally accepted definition. And there's this really boring table here from a recent review article looking at, all these different countries and all these different organizations and the requirements that vary between all of them for how we're going to define asthma COPD overlap. So that's why we all get in a room and argue about what this disease entity actually is, which is kind of ridiculous. But nonetheless, we can't decide how high the eosinophil count has to be. We can't decide how atopic they have to be. We can't decide, most importantly, how, what their PFTs have to look like and how much bronchodilator reversibility there has to be to say, oh, this is a significant asthma component. How long do they have to smoke before we say that there's a COPD component and it's not just fixed obstruction from long-standing poor asthma? So a number of different things that are, marginally important, but sort of clouding our diagnosis of asthma COPD overlap. If you look at GINA, so GINA is the global guideline in diagnosing and managing asthma. And so if you look at their definition, this seems pretty simple and straightforward. And that is that these patients have persistent airflow. That is part of chronic obstructive pulmonary disease, is obstruction that is persistent. And they have features of both. They have features of asthma, they have features of COPD, and therefore they have asthma COPD overlap. A pretty, common sense definition. And I like common sense, but common sense is hard to teach. So I've got 5 kids, I'm doing my best. So if we start thinking about chronic diseases and COPD, we have to think about the history that we take with the patient. We have to think about physical exam findings. X-rays help us, particularly with COPD. We may see some upper lobe predominant hyperinflation, some lucency. It's not quite as white in the upper parts of the lung fields, and that suggests that there's some emphysema present. And then, asking a lot of questions, and we actually have validated questionnaires that can help us objectively determine the symptoms the patients have with their chronic disease at baseline, and we start therapy, and then we look and see how much objective improvement is there with our care and our treatment and our pharmacologic and non-pharmacologic interventions, and we're going to talk some about those as well. This is kind of a busy but nice table that looks at the typical symptoms of asthma versus COPD, and then what we'd expect in asthma COPD overlap. So let me go through this kind of briefly and emphasize a few points. Asthma we think of as a childhood illness, but adults, particularly with eosinophilic asthma, can develop asthma later on in life, in their 30s, 40s, and 50s. But we classically think of asthma early, COPD late, after age 40, with smoking. But, we have to be cautious here. I'm seeing patients who start smoking when they're 13 years old, and they've been smoking now for 20, 25 years, and they're still in their 30s, and they have emphysema. So that 40-year-old age cutoff, I think, is kind of irrelevant. It has more to do with smoke exposure and other environmental exposures. But nonetheless, asthma earlier, COPD tends to be later. Asthma tends to be kind of on and off symptoms. They have good days, they have bad days. COPD, they have kind of, every day is not a great day for them. Lung function can be completely normal in asthma, and that's what I see most frequently is I catch them in between their symptoms and their PFTs are normal. That's always the way it goes, right? You go see your doctor and your symptoms gone. But they can have obstruction. With COPD, you commonly have obstruction on your PFTs each time that spirometry or complete PFT is done. Again, asthma, you can have symptoms in between flares or in between exposures, FEV1, pretty typical symptoms. Chest X-ray is usually normal in asthma, and we kind of talked about what we normally see in COPD. Both of these conditions tend to exacerbate, and so we have to be thoughtful about that. And we also have to be thoughtful about the inflammation that's driving asthma, because asthma tends to be what we call type 2 inflammation. It's more related to eosinophils which we can identify on their CBC with differential in Cerner and just look at the absolute eosinophil count at the bottom, and it'll say 0.1 or 0.2 or 1.0. 0.1 is 100, 0.2 is 200, 1.0 is 1,000. Normal is less than 150. And we frequently see a high eosinophil count, particularly in this region in asthma. COPD can have eosinophils, but classically this is more of a neutrophilic condition, which is non-type 2 inflammation. That's not that important, but our approach to managing these patients is different, as we will talk about. Just a little bit of pathophys here. With regards to development of asthma, COPD overlap, most patients with asthma have some sort of genetic predisposition to developing asthma, either literally in utero or with early life factors and exposures, RSV and these sorts of things that may prime the airway and make patients susceptible to developing asthma. They then develop asthma symptoms earlier on in life, and then they start smoking or they have some other environmental, occupational exposure, pollution, whatever, that ultimately leads to that fixed obstruction and perhaps some emphysema. And now this patient is left on the Venn diagram here with that ACO, that asthma COPD overlap right there in the middle. One of the complicating things with asthma COPD overlap is that there's different subtypes. So we've got asthmatics who smoke, and by definition, they smoked one cigarette, so they have to have COPD. But in fact, it's a smoking asthmatic, as opposed to a patient with COPD who later on in life develops eosinophilic asthma, and this is now eosinophilic COPD. We can also have patients who have asthma for decades, and they will develop fixed obstruction from airway remodeling, and that too is a whole different subtype of asthma COPD overlap. So there can be a number of different presentations with these patients, which complicates things a little bit. But the reason why this is important is the fact that these patients have worse outcomes than true, just pure asthmatics, if you will, or patients who, quote, only have COPD. They exacerbate more. They have higher morbidity and they have a higher risk of mortality. So just briefly, how do we sort of, test these patients and make these definitions? I've already alluded to the importance of spirometry and PFTs. I'll tell you, we have a lot of patients running around with a diagnosis of COPD that have never had a spirometry. Some of these patients have heart failure, have bronchiectasis, have, non-cardiac, non-pulmonary reasons for their dyspnea. And so it behooves us to get spirometry to formalize a diagnosis and confirm that they have COPD and may have asthma COPD overlap. So that is important. A pre-post spirometry, which is a really simple test. So they do spirometry, we give them albuterol, we wait several minutes, we repeat the test, we look and see how much their FEV1, how much air they can force out in the first second of spirometry. How much that changes, and that gives us an idea of reversibility and reactivity of the airway and the likelihood that there is an asthma component. I'm not going to say a whole lot about FeNO, the fractional excretion of nitric oxide, but this is a test that we in pulmonary can do, and we can measure the nitric oxide gas in a patient's breath, and that can serve as a surrogate marker of the inflammation in their airway. This gets a little muddied in asthma COPD overlap because smoking lowers the nitric oxide level, obstruction lowers it, bacon increases it, and I love bacon. So there's a lot of things that can go wrong with the FeNO, but it can be marginally helpful. What is extremely helpful are eosinophils and IgE levels. And eosinophils are easy to find. It's just a little ploy. If you're going to check a CBC, do me a favor and just click the width differential because it helps me a lot as a subspecialist to gain an idea looking retrospectively as to whether or not they have eosinophils. We can also check IgE. This is a marker of how atopic a patient is, and our allergists can help us determine if they're atopic. If our patient doesn't have ready access to an allergist, we can do a simple serum test which is an IgE specific allergy test. Simple serum test, costs $200. Very easy to do, and we can check all of the regional allergens and see if patients respond to them and are atopic. And this will give us some idea about their inflammation and how much asthma is contributing to their COPD symptoms. Because therapy is going to matter depending upon this. We'll start with the inhalers first. With COPD, if there's anything to take away here, with COPD, we think about bronchodilators first. So we want to give them a LABA and or a LAMA, usually in combination, because the evidence is that the two together will be the most beneficial in improving symptoms and reducing exacerbation rates. We want to start with those bronchodilators first. And we will add inhaled corticosteroids in COPD if they contribute to or continue to exacerbate, and we'll talk more about that. Asthma is the opposite. With asthma, it's more of an inflammatory condition. So we start with the inhaled corticosteroids first, and if they're still symptomatic and exacerbating, then we add the second and third component, the LABA first, and then there is evidence for LAMA in asthma as well. But as we will talk about with this overlap, these patients really ought to be on all three. They need to be on triple therapy, the steroid and the dual bronchodilators, to improve their lung function and overall to improve their symptomatology. So as mentioned, triple therapy is the way to go in these patients, and we have two inhalers on the market that have all three ingredients in one inhaler, and then sometimes we have to combine two separate inhalers to get the triple therapy. But of course, most patients don't want to use two medicines, and that can reduce adherence. But nonetheless, triple therapy is important, and we've got a lot of good options in 2024. So that's kind of my information on the inhalers. Macrolides, so azithromycin, the simple Z-Pak that most of us think about as a placebo when somebody's got an upper respiratory infection, actually has a really important role in both COPD and asthma when taken chronically. So, azithromycin, yes, it's an antibiotic, but it has really important anti-inflammatory and immunomodulatory effects on the airway. So it really has a significant impact in some patients with COPD in reducing exacerbation rates. And so this, as I'll show you, can be an add-on therapy to triple therapy in patients with asthma COPD overlap who continue to exacerbate. There's a medication on the market called roflumilast. Daliresp is the trade name. It's been around for a long time, and there's evidence for this in reducing exacerbation rates. In my experience, the azithromycin is more effective, and there's actually been a head-to-head study looking at this done through the VA system, and azithromycin 250 milligrams daily was more effective in reducing exacerbation rates. There's some early evidence that maybe Daliresp works in asthma, but this is not yet guideline recommended, so I wouldn't recommend it just yet in our asthma patients, but it may have a role in our asthma COPD overlap patients. Now we're getting into the fun stuff that I love to talk about, and that is the biologics. So you're aware of biologics, certainly in rheumatology. We now have biologics in oncology, and we are fortunate to have biologics in pulmonary as well, classically for asthma, but as I will share with you, now one approved for COPD as of last Friday. So things are always evolving in pulmonary, which is making it more and more fun every day. But there's a variety of different biologics that we have that target some of those inflammatory mediators that are leading to activation and propagation of eosinophils, and some of them target IgE and bring that level down to reduce the allergy component in asthma, and certainly in asthma, COPD overlap patients as well, depending upon what inflammation is driving their symptoms. And so we've got some preliminary evidence that some of the biologics kind of maybe worked. So omalizumab, Xolair has been around since 2003. So this has been around for more than 20 years now. And there's a little bit of evidence that it might help in these patients, but it's not yet approved in COPD. But maybe the right asthma, COPD overlap patient that is very atopic, maybe you'll get a response, but I rarely use this drug anymore because we've got newer drugs that are way more effective. So mepolizumab came on to the market in 2015. So Nucala, it's been around for a while. It works very well in patients with an eosinophilic phenotype of asthma, and it might have a little signal in COPD, but it's not yet approved in COPD. But again, perhaps in asthma COPD overlap, there will be some benefit. And the same is true of benralizumab, or Fasenra. So this is another biologic that's available for our eosinophilic asthma patients. Here, there's not only evidence for improvement in asthma symptoms, but some of those patients like the one I presented who may be steroid dependent, there's evidence that if we start this biologic, we can taper off of the prednisone and reduce the toxic effects of the prednisone in an asthma COPD overlap patient. But again, not yet approved just in COPD. Enter dupilumab or Dupixent. So this is the drug that just last Friday actually got an FDA indication for COPD alone. So I think many of us who are looking at our asthma COPD overlap patients with an eosinophilic phenotype, high eosinophils, and perhaps atopic, I think this is a biologic we're going to be considering more seriously now because it is in fact approved in COPD based upon this evidence. So when we put a patient with COPD on triple therapy, we can anticipate about a 20% reduction in exacerbation rates. That's pretty good. If you look at the number needed to treat, depending upon the patient and what you're comparing to, the number needed to treat is between 3 and 7. So let's take the worst case scenario. For every 7th patient you put on triple therapy, they're going to have 1 less exacerbation in a year. That is pretty good data, okay? Now we look at this, dupilumab. This was studied in patients already on triple therapy. And now we put them on Dupixent and we follow them for 52 weeks. And there's a further 30 to 34% reduction in exacerbation rates on top of the benefit that they're already getting from their triple therapy. This is really exciting. This is really significant. This is really an opportunity to improve patient symptoms, to reduce exacerbation rates, to reduce how much prednisone they're getting, improve their quality of life, et cetera. So these are the 2 landmark studies called Boreas and Notice that the FDA just reviewed, and literally last Friday, September 27th, said, yep, you get the indication for COPD. So we're pretty excited because we've got another, arrow in our quiver, if you will, for treating patients with COPD, and in particular, the patient population we're talking about right now with asthma, COPD overlap syndrome. This is kind of a nerdy cartoon that shows you the inflammatory cascade in the airway of patients with asthma and COPD, and all of those medications that I just spoke with you about, kind of which inflammatory mediator it's targeting, and then why it's going to have an impact in improving, or let me say this, reducing inflammation, and thereafter improving outcomes. So just kind of a nice cartoon schematic of this is the target that this biologic is going after to block all of the downstream inflammation with a significant effect. Kind of putting all of this together back to our asthma COPD overlap, again, it's important to look at them and say, does this patient kind of more have asthma, or do they more have COPD based upon their clinical characteristics, and then choose the appropriate medical therapy depending upon which condition or which phenotype we think is more likely causing their symptoms. This would be another way of looking at it and saying, okay, I think, this is COPD, or this is more asthma, or right there, asthma, COPD overlap in the middle. And we'll kind of focus on that. And we'll see, again, most of these patients end up on triple therapy. But then we're looking for treatable traits, and I'll say more about that in a minute. But we're looking at them to say, is this more COPD, or is this more asthma? Because if it's more asthma, and I personally would hope it's more asthma, because we've got these biologics that can have a very significant impact. And if we identify that, we figure out which biomarker is driving their inflammation. Do I want to target the eosinophils? Do I want to target the IgE? I pick the right drug, and the patient lives happily ever after. With COPD, unfortunately, we have fewer choices, but we do have azithromycin. We do have this roflumilast. So we've got other options on this side as well. Most of this comes from the guidelines. So I want to show you, sort of the primary evidence that is guiding us here. So this is the GOLD guideline for COPD. I mentioned GINA, and I'll show you that in the next 2 slides. But GOLD here is a really nice, short, 300-page guideline that helps us determine how we treat COPD. And I can summarize all of it into these 2 slides. So we determine how symptomatic they are over here with validated questionnaires, and I use the CAT score, the COPD assessment test, that is an 8-question questionnaire that a patient fills out 0 to 5 for how symptomatic are you with this cough or dyspnea, etc. And the higher the score, the more symptomatic. And then over here on the y-axis, we look at exacerbation rates, moderate or severe, and then we put them into a group. And unfortunately, most of my patients live right here in group E, E being exacerbate. And these patients, have 2 or more exacerbations per year. They need prednisone and or an antibiotic twice per year. A severe exacerbation is one that leads to an exacerbation. If that happens once, we want to be more aggressive. So most of these patients at a minimum, as mentioned, need dual bronchodilator. They need the LABA or the LAMA. But if they're eosinophilic, we should put them on a triple inhaler right away and then bring them back. And if they continue to exacerbate, we're over here. So if we only put them on a LAMA or a LABA, we better put them on triple therapy. If they're continuing to exacerbate, again, we've got this choices, but the next edition of GOLD is going to have a box right over here for dupilumab for the reasons that we already talked about. Coming back to asthma, here is the GINA stepwise their approach to therapy that some of you may be familiar with, although this has changed significantly in the last few years with what we call MART therapy, maintenance and reliever therapy. So this would be Symbicort. So this is a combination inhaler. It's the only one that we have in the United States that we can use for this. The problem is it's not FDA approved in the United States for us to do track 1, which is preferred by GINA. So we kind of have to live down here where we put patients on other combination inhalers with an ICS and a LABA, and then we ramp up the dose of the ICS and the LABA. And if they're still symptomatic and exacerbating, well, then we might add a 3rd inhaler ingredient, and then we check them for their eosinophils and their IgE and maybe that pheno that I told you about, and then hopefully send them to me or one of my partners, and we look at things very carefully and we choose an appropriate biologic. And we have, treatment guidelines like this one that was recently published in the New England Journal that we look at their biomarkers, their eosinophil count and how high it is, their IgE, if there's overlap between the 2. Many of these patients have atopic dermatitis or nasal polyps or eosinophilic esophagitis. other inflammatory conditions that these drugs can treat. So as a 2-for-1, we could treat 2 medical conditions with 1 drug if we're careful in identifying the patient and what symptomatology they are all having. To kind of round things out here, I've talked a lot about medications, but equally importantly are the non-pharmacologic interventions that we can have for our patients with asthma COPD overlap. Every day I have to counsel patients on smoking cessation and refer them to the Quit line as a great resource both for pharmacologic therapy to help them stop smoking, counseling, etc. So 1-800-QUIT now is a great resource for patients because unfortunately we don't have a lot of other great resources locally to help them. Inhaler technique is really important. There's good evidence to say patients don't know how to use these complex inhalers that we just kind of throw into their hand. And in fact, many providers don't even know how to use the inhaler. So it's important for us to know how to use it so we can show our patients how to use it, because if they're not using it right, it is not getting into their lungs. We want to help them avoid triggers, and we talk to them about keeping the cat out of the bedroom and those sorts of things. Treating comorbidities, many of these patients have heart disease and they need to see Dr. Olson too. And so, we screen for any ischemic symptoms or certainly send them his way if we think that the heart may be involved as well. Pulmonary rehab is a great resource in asthma COPD overlap, and actually both for asthma and COPD, and can have a significant impact in improving symptoms and reducing exacerbation rates. Vaccines help patients avoid exacerbations, oxygen in those patients that need it, and we should be screening for alpha-1 antitrypsin deficiency in this group. 1% to 2% of our population is alpha-1 deficient, and we don't find it unless we look for it. And if we find it, we've got another therapeutic target. The reality of it is, we've got a lot of these patients and we've got some evidence, but we need some more evidence in our approach to managing these patients. So I'll wrap it up here. So we've got a few minutes for questions before our next talk. But hopefully I've shown you this is a widely prevalent condition. Again, 30% to 40% of our patients with COPD have overlapping asthma symptoms and phenotype as well. And we won't identify that unless we ask and we look for it. This is kind of an exciting thing for us. It's another target, and it's really important for us to think about how much asthma is contributing to the COPD and then choose the right therapy, the right intervention to help them. We need more mechanistic study to better understand why patients develop asthma COPD overlap, so we can avoid it. And obviously, if we could take away cigarettes, that'd be a great start, but we don't have that opportunity currently. And as mentioned, we need larger randomized studies that include both groups with these pharmacologic therapies, not excluding asthma or COPD, so we can have a better idea of what intervention is going to be most effective in this somewhat complicated group of patients. I'd be happy to take any questions now. So thank you.
Do you find that vaping is just as bad as smoking, or better or worse?
That's always a really hard question to answer. The problem with vaping is it's not FDA regulated. We don't know what is in that vape juice. That's just a reality. Keep in mind, several years ago, we had a pandemic of vaping-induced lung injury before we had a pandemic with COVID. And somehow it went away with COVID. It's still there. We're still seeing a little bit of vaping-induced lung injury. It's a characteristic pattern on CT. I'm dancing around your question. Vaping is detrimental to the lung as well. It is. So some of this, advertisement, it'll help you stop smoking. No, it's more of a gateway to start smoking than a smoking cessation aid. And it still has detrimental effects to the lung, perhaps less, and there are some studies to suggest that that's true, but still detrimental. And I counsel my patients against vaping, and I certainly counsel my kids against vaping. So great question, kind of a murky answer. Yes?
Are there areas of the country that have more prevalence of COPD and asthma than other areas?
So it's widely prevalent, both asthma and COPD. COPD more prevalent given the, smoking going on in different, southeast and different regions of the country. Asthma, there are certainly hot pockets of asthma. And in fact, let me make a plug for the Allergy and Asthma Foundation of America. They have a top 100 list of cities most difficult to live with asthma. So these are cities in different regions of the United States where there's a bigger prevalence of asthma, there's higher rate of ER visits, and there's a higher mortality. Omaha is always on that list. And in fact, 5 years ago, we were top 10. Last year, we were 18, and we were number 8 for mortality. The 8th highest city in the country for asthma-related deaths. This year, we're 34. So, many of us in pulmonary, allergy, et cetera, are really trying to be aggressive with biologics and just appropriate identification and treatment of these patients, and it's working. We're getting better locally, but we're still number 34 out of 100. So yes, there are hot pockets. It has to do with environmental exposure. Go outside and look at the dust out there right now with the bean harvest. Those are triggers. Corn's coming soon. I mean, we've always got something triggering asthma, and then it's our genetics as well that play a role. We have a lot of type 2 inflammation here. Many patients are atopic and have a high eosinophil count, and that is part of why our outcomes are poor and why our prevalence is high. But we can have meaningful impact and we can improve outcomes. All right, great questions.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.